So I am going to give our progress report this year on update for pancreatic cancer. And in the talk, I'm going to try and show the state-of-the-art care that we're doing at the Aggie Hirshberg UCLA Center for Pancreatic Diseases and give you a good sense of how we as clinicians think about treating patients with pancreatic cancer. Just a few disclosures to report for some of the clinical work that we're doing and also some preclinical work that we're doing in the laboratory. So the agenda of the talk is first a changing landscape, which is unfortunately the rise of pancreatic cancer in younger people that we're seeing. Emily mentioned genetic testing and tumor testing, but I want to re-emphasize how important that is and that there are two keys to better care. How we treat advanced pancreatic cancer today. Sure, many of you have heard about these KRAS inhibitors, which is the so-called new magic bullet for pancreatic cancer. But there's so many trials that are ongoing. Many of which we have here at UCLA. And also talk about immunotherapy. This has been one tumor that's been pretty resistant to checkpoint inhibitors or immunotherapy. I'm sure many of you have heard of immunotherapies. You don't need to do more than watch the Super Bowl and they're on commercials or whatnot. But I think that there may be some potential breakthroughs of immunotherapy for pancreatic cancer. Finally. Okay, summary statistics. Pancreas cancer 2025. New diagnosis last year was 66,440, which is up a little bit. I remember when we first were talking about this, it was down in the 50,000s, but now it's up in the 60,000s. 8th to 10th most common cancer, 3% of new cancers. The incidence is increasing about 1% per year, which is too much. And if you look globally, it's the number 12 most common cause of cancer. Just over 500,000 people a year globally are diagnosed with pancreatic cancer. What are the symptoms at diagnosis? This is like hot off the press. It was just published in a very preeminent journal, The Lancet. I actually just saw it this morning. I'll reveal a little bit here in the spirit of transparency. One of the first things I do when I wake up is look at Twitter. And I was looking at Twitter this morning, and I saw that this article had been published. Literally, it's like a few days old. But this is the symptoms at diagnosis. I'm sure many of you have experienced these when you were first diagnosed. Some of the more common ones are dyspepsia or indigestion. New onset diabetes. I think that's a really important one. If you know friends that for unknown reasons are developing new onset diabetes, I think one has to be somewhat suspicious that there's something wrong with their pancreas. Hopefully not cancer, but it's possible. Abdominal pain, pretty nonspecific, so many causes for that. Jaundice, right? So if the tumors develop in the head of the pancreas, people can get jaundiced. And then constipation there. This was just in the New York Times this week. Why are so many young adults getting cancer? April 4th, there was an essay there. And the person who wrote it is a oncologist at the Brigham and Women's Hospital, or I guess it's Mass General Brigham now, and talked about that there must be some exposure in the environment or what we're eating that's been going on for decades now that's causing the incidence of cancer to go up in younger people. And she implored the current government administration to focus on this rather than vaccines. Definitions of early onset and average onset cancer. So we think about early onset. Early onset pancreatic cancer is patients who are less than 50 years old or people less than 50 that get it. Average onset is is greater than 50 years. So here's early onset gastrointestinal cancers. So it's happening not only in pancreatic cancer, but colon and rectal cancer, stomach cancer, higher incidence, increasing incidence at age less than 50. The one in the blue box on the right there is pancreatic cancer. The green line is males, the blue line is females. And you can see for pancreas, the early onset, that it's at the top there. It's going up in both males and females. But on the bottom, it's average onset and going up a little bit in males and a little bit in females, but certainly not as much as the early onset. What are the risk factors? Why is it thought that younger people are getting this disease? I've circled in blue the ones that are pertinent to pancreatic cancer, but it's high BMI, so obesity is thought to potentially be a risk factor. Gita Leibel is here, and Joe Hines have done a lot of work on that in the laboratory. Smoking and alcohol use, but not many other pancreatic cancer risk factors that we know of. We talked, as I mentioned, we're going to talk about inhibiting KRAS. KRAS it's the gene that's thought to cause pancreatic cancer, what we call a founder mutation, the main mutation that happens that causes tumors to develop. And overall, it's thought to be in 95+% of these pancreatic cancers that are driving it. But what we found is the early onset pancreas cancer, that incidence or percentage of KRAS is lower. You can see it's only 83%, and I told you overall it's over 95%. And this is thought because there are other mutations that are inherited that these younger people who are getting pancreatic cancer have. And as down there, 32% have a genetic predisposition. So the mutational profile is a little bit different in younger people, and a lot of them are getting pancreatic cancer because of an inherited mutation. Fortunately, patients with early onset pancreatic cancer, so younger patients, live a little bit longer than those on average onset. So they're getting it earlier, but their disease is not quite as aggressive. So a changing landscape, the rise of pancreatic cancer in younger people. So average onset is more common, fortunately, than early onset. Median age diagnosis is 71 years. These early onset pancreas cancer, the incidence is increasing, both in males and in females. Unique genetic considerations, so a lot of them have what we call germline mutations or inheritable risk of developing pancreatic cancer. Some modifiable risk factors, BMI, smoking, alcohol intake. Their outcome may be a little bit better. And public health considerations are that people should consider lifestyle factors like smoking, obesity, diet, exercise. And those who do have confirmed, documented mutations or inheritable mutations, there are national studies, like one that we have here at UCLA, to surveil these people, monitor them for developing pancreatic cancer. It's called the PRECEDE study. We had the main leader of that study, Diane Simeone, here last year. So her talk is on the website for you to watch. But those of you who are at an increased risk of developing pancreatic cancer because of some mutation, please reach out to us because we can help you. Next is genetic and tumor testing, two keys to better care. And so there's two different types of genetic testing that you can get. One is called germline testing. I see Wendy Conlin is here, our main genetic counselor, and somatic testing. Germline testing is you just get it with giving a blood sample or a saliva sample, and it's mutations that are in every cell in your body. They're ones that you inherit. They're all over. as opposed to somatic testing, those are mutations that are specific within your tumor. So it's pretty much recommended that all patients who are diagnosed with pancreatic cancer get germline testing, and most or all also get somatic testing, so testing of your tumor, because there are definitely mutations in your tumor, like that KRAS mutation that I talked about, that's specific to the tumor and isn't necessarily in all cells of your body. On the right there is the mutational profile of pancreatic cancer. So each row is a different gene, and each column is a different tumor that they've tested. And the point I want to get across here is that there are many mutations that can be present within this tumor, many different ones. The most common that's up at the top there is that KRAS gene, which we'll talk about a little bit later. Why is it important to get your germline testing and somatic testing? It's because now it can potentially affect your treatment. We have different drugs that target specific mutations within your tumor, and we have different drugs that we can give you if you have these germline mutations. So I will give you some examples that really hammer this point home, where this information has helped treat our patients. Here's one, for example. There's this thing called microsatellite instability, whereas there are some patients that have these germline mutations that just don't repair their DNA well. There's constantly mutations that are forming in our DNA, and nature has adapted to this and developed repair mechanisms to fix those mutations that are constantly happening. But there are some patients or people that have mutations, germline, all over their body, in the proteins or the genes that help to repair that DNA. And so these people are much more sensitive to checkpoint inhibitors, those commercials on the Super Bowl, or immunotherapies, because of all the mutations that are happening. Your immune system is seeing them as foreign. And so if we give you this immunotherapy, we're just going to rev up your immune system to fight that tumor. Here's a good example of this. So this is a patient of mine who was diagnosed 2016, a while ago, when we were not doing germline and somatic testing for patients routinely. And so we saw them and gave them just the standard of care, chemotherapy, like we would for anyone. But then it wasn't really working. So we then got the genetic testing and found that this patient had one of those mutations that doesn't make them repair their DNA as well. And so we switched from this chemo that they got for 8 months, and we put them on just one immunotherapy pill or a checkpoint inhibitor pill. And you can see the tumor markedly shrunk down by giving them better treatment because of the mutational profile. Here's another example. So 2017, patient got chemo, not tolerating the treatment well, and we then did the testing later, after the fact, or after we had treated him or her for, 5 or 6 months or so. Again, found that they had the mutation in that repair gene and switched them to the immunotherapy. And you can see the tumor shrunk down pretty markedly. Unfortunately, only about 1 or 2% of patients with pancreatic cancer have a mutation in this DNA repair gene. But that's 1 or 2%. And there are many other genes that can also be mutated in the germline or in the tumor that can help predict responses to therapies. This is another mutation that's specific to the tumor. It's called NRG fusion, where again, we have specific drugs that target this fusion protein. Tumors are very responsive to it, and the treatment is very, very well tolerated, much better than the cytotoxic chemotherapy. One of our sponsors for the meeting today is A2 Biotherapeutics. And this is another example and a treatment that we have here at UCLA, specifically in a clinical trial, where it's important to do that germline and somatic testing. So this is a state-of-the-art treatment with these CAR T cells, which are essentially supercharged immune cells that can fight tumors. But only patients that have specific haplotypes in their blood, which we can determine from germline testing, and a loss of a gene in their tumor are eligible to get this treatment. But it's a really, really effective treatment, but we only know if you're eligible if we do this kind of testing. But something that we do routinely do here at UCLA to give you the state-of-the-art treatments. Here's an example of a patient who got treated with one of these supercharged T cells, these CAR T cells. You can see the CT scan on the top, had metastatic pancreatic cancer. And there's the baseline scan where you can see the metastasis in the lung, and then got these supercharged T cells in a 30-day follow-up, a 90-day follow-up. The tumor is completely eradicated and gone. And so, again, another reason to get that genetic testing because it might help you be eligible for better, more well-tolerated treatments. This is just a workflow diagram that we have to ensure that every patient is tested within the clinic. So how we treat advanced pancreatic cancer today in general. Another example of where we're leading the way here at UCLA, this is one of our medical oncologists, Ev Wainberg, who led this international clinical trial that was a trial to approve this drug or combination called NALIRIFOX. It's the first time that a new drug has been FDA approved for pancreatic cancer in the last 10 years. And one of our oncologists is the one that's leading this trial. It's essentially FOLFIRINOX, which I'm sure many of you know FOLFIRINOX, and it's called 5FU for a reason. But this is a new, novel way to give one of the drugs in that combination. But for the most part, general treatment for pancreatic cancer is FOLFIRINOX or the gemcitabine and Abraxane. Those are the first two regimens, or what are thought to be the most effective regimens. But this NALIRIFOX is just a variant of that FOLFIRINOX. But again, really proud that a member of our team is helping to develop this. This is a trial or a slide that Dr. O'Reilly, who gave this talk last year from Memorial Sloan Kettering, presented and I really liked. And it's something that was never thought of before prior to us having better chemotherapy treatments for pancreas cancer. So this is a trial where they looked at patients who had metastases, spread from their pancreas to their liver. And what they tested is, does a local therapy targeting the spread tumor in the liver, does it make sense, right? So we used to think that, if the tumor is spread outside of the pancreas, that local therapies aren't necessarily helpful. But what we're starting to think about and starting to learn about with this is, I hate survival curves, but just this one. What we're starting to think about is that we can maybe think about these metastatic lesions, as long as there aren't too many of them, with local therapies. And it's because the chemotherapy or the systemic therapies that many of you are getting are doing much better. So just because it has spread to the liver, as long as there's not too much, that it still might make sense, or make sense more now, to give a local therapy to address those metastases and not just give chemotherapy alone. But it's changing the way that we're thinking about treating this tumor. So standard therapy, 2025, the chemotherapy is FOLFIRINOX or gemcitabine and Abraxane. There's this new variant called NALIRIFOX that our team has been helping to develop, and as I said, first FDA-approved therapeutic for this disease specifically for this disease in the last 10 years. Maintenance therapy, so patients after they get this really aggressive chemo, a less aggressive or intensive therapy like Judith talked about with her Xeloda and irinotecan for a maintenance therapy. An emerging area is immunotherapy or targeted therapies, which we'll talk about a little bit. And then building on the standard, as I said, starting to think about local therapy, even if the tumor has spread outside of the pancreas. So these KRAS inhibitors are next. So the so-called magic bullet potentially for pancreatic cancer. There's so many trials going on right now testing these drugs for pancreatic cancer patients. So I said KRAS is the main mutation or oncogene that causes or drives this tumor, present in 95+%, lower so in early onset pancreatic cancer. So this is the tumor that needs these drugs, right? It really does. Here's all the therapies that are currently in development or being tested against KRAS. There's so many of them. There's so much activity in this space. There's so many strategies that are being tried to inhibit this or tackle this mutation. Here's one example of a drug from Revolution Medicines, which is a pan-KRAS inhibitor. But this, on the left, is what we call either a waterfall plot or a swimmer's plot. And the bars that are above the line are patients who didn't respond to the treatment. And the bars below the line are patients who responded to the treatment. This is a dose escalation. So as they escalated the dose, they noticed that patients were responding really, really well. I really do think that these drugs in time will be FDA approved for this disease. And folks are responding to them. But resistance will invariably develop. So the challenge for us, I think, going forward is going to be able to find the optimal combinations of therapies for patients with what we call a KRAS inhibitor backbone treatment. But on the right there is a patient who was on the trial, where again you can see the baseline. There's a metastasis in the lung there. That while on treatment, it went away, or there were several metastases in the lung that went away. We have many trials with KRAS inhibitors that are open here at UCLA. And again, our ability to give you the best, most possible state-of-the-art therapy. So KRAS, critical regulator of pancreatic cancer. So many therapies that are being tested against it now. Biotech and pharma are doing a great job developing drugs for this difficult to treat mutation. And our challenge now is to make them better, but to find out what are the optimal combinations that work with it. And on immunotherapy, potential breakthroughs finally. I'd like to talk to you a little bit about the work that we're doing here. There are different stages of tumors that we anatomically stage when you're first diagnosed. Many of you probably know this, but the pancreas, unfortunately, these tumors can spread to other organs quickly, which we call metastatic disease. But the pancreas is also located next to all these essential blood vessels. And it doesn't take much growth for a tumor to involve the blood vessels around the pancreas. The V is a vein, the A is an artery there. And you can see that only a small number are what we consider to be resectable up front, where the tumor there, or the T, is confined to the pancreas. Most patients present with either disease that are spread elsewhere or have grown just a little bit to involve those blood vessels around the pancreas. That borderline resectable category in the middle is one that we're really focusing on because the treatment for these patients, or as recommended by the National Comprehensive Cancer Network, is to get some treatment up front before surgery. And that's to try and shrink the tumor, downstage the tumor, have it shrink away from these blood vessels so when you ultimately do get surgery, it's not as complex. And to make sure that the surgery will really help you to go into surgery feeling confident that surgery is helpful. But again, treatment up front, as Emily talked about, this is called neoadjuvant therapy. And we think it's an optimal space to try and improve survival, but also study drugs and figure out how they're working, or more importantly, why they may not be working. So this is one trial that we did here at UCLA where we asked a simple question. So patients with borderline resectable disease who needed to get treated before surgery, who we knew or a large majority were going to go to surgery, we took that standard of care FOLFIRINOX and we added an immune checkpoint inhibitor, this anti-PD-1, just as a first step to see if immunotherapy would help chemotherapy in these patients who were going to go to surgery. And unfortunately, we found that the immunotherapy didn't really do much. Patients' survival was similar to those who just got chemotherapy beforehand. But we didn't quit there. We started to think about and ask why it wasn't working so much. And what we found is that comparing biopsies from when people were diagnosed to their surgical resection specimens, that they had an increase in this adenosine signature within their tumors. Adenosine is a super immunosuppressive molecule. So we were given chemo, an immune checkpoint inhibitor, but these tumors were adapting to this by increasing this immunosuppressive molecule to keep the immunotherapy from working. And the main enzyme that makes adenosine is the CD73. So we thought to ourselves, let's start another study where we're going to give the chemo, the immune checkpoint inhibitor, and a CD73 blocker to try and prevent the tumors from being able to upregulate this adenosine. I know several of you in this room who are on this trial. And again, borderline resectable disease, patients who need to be treated before surgery, who we know are going to go to surgery, or most are, but we're going to treat them during this period with the chemo, the checkpoint inhibitor, and this adenosine blocker to hope that their tumors respond better. But when we take them to surgery, we're going to take those tumors and we're going to run them in the laboratory to try and figure out how this is working. And so we've enrolled 28 patients already, and 14 patients have gone to surgery. But this, you can see the left, everybody knows CA19-9. Almost all CA19-9 responded, so lower after treatment. There's just a very few who we considered non-responders because their CA19-9 went up. But I said 14 patients went to surgery, so all patients who completed their treatment who were eligible for surgery have had surgery. So we have not yet seen any progressors on therapy. On the right there, you can see the CT-MRI. All the bars are down. Everybody's tumors, at least radiographically, look like that they're responding to this combination. Here's some examples. You can see a bunch of CTs on the top row and then the bottom row. And then the percent is the percent that the tumors are shrinking while they're on this treatment. So chemotherapy, checkpoint inhibitor, and this immunotherapy that we're really excited about. Most people are responding. And so this table just shows at least the initial signal that we're getting from this treatment. On the right there is the trial where we're giving chemo, immunotherapy, and the CD73 inhibitor. All 14 patients who we've taken to surgery, not one of them has a positive lymph node. Everyone has negative lymph nodes. If you look at the bottom, the treatment score, 42% of patients have what we call a major histopathologic response. So when the pathologist looks under the microscope, they see that the tumors are markedly responding to the treatment. If you compare that right column to the middle column, which is the FOLFIRINOX and the immunotherapy, the first trial that we did, When we're adding this adenosine blocker, the responses in these tumors are getting much better. And then on the left there is just a larger trial where they gave chemotherapy only. 0% of patients had this complete response, where we're seeing some with this adenosine-targeted immunotherapy. So we're really excited about this, really excited to see what happens with the additional 14 patients who we haven't taken to surgery yet. And we're actually in communication with the company about expanding this to a prospective randomized study where we're going to be able to study it a little bit better in a controlled fashion. But again, state-of-the-art treatment that you're going to get when you come to UCLA. This is one other immunotherapy thing that I wanted to talk about briefly. This is being run out of Memorial Sloan Kettering. We have it open here. It's mRNA vaccine trial for pancreatic cancer. Essentially, Vinod Balachandran, a surgeon scientist at Memorial Sloan Kettering, found that in patients who survived a long time, they had more T cells, anti-tumor T cells in their blood when he looked greater than 7 years later. So thought that there was an immune component to people being able to beat this disease. And so what he's really worked on is developing mRNA vaccines, like the vaccine that everybody got for COVID, or most people got for COVID, because it induces a pretty robust immune response. And so this trial that we have open here now is for patients after surgery, where we take out their tumor, gets flown to Germany, where it gets profiled for the specific mutations that are in the tumor. They develop this mRNA vaccine for folks, and then we fly it back here, and we give it to them with chemotherapy and immune checkpoint inhibitor. But another example where there's a lot of excitement around immunotherapy for pancreatic cancer, but this in the form of mRNA vaccine. So, summary of 2025, current and future. Standard therapy, it's the chemo for the most part, the FOLFIRINOX, the gemcitabine and Abraxane, but this NALIRIFOX, first FDA-approved drug in the last 10 years, really led by one of our team members. A genomic-based therapy, it's so important to get germline testing, to get somatic testing, because there may be something there that we call either targetable or actionable, where we might be able to find you a more effective therapy that isn't necessarily as toxic. And emerging therapies, I think, an eye towards the future that we're really excited about are these RAS inhibitors, that driver oncogene, the magic bullet for pancreatic cancer. They're not going to work alone. We're working really hard to figure out the optimal combinations. And I do think immunotherapy is possible for this tumor, and certainly we'll live to see another day for treatment. So that's where we are in 2025 for pancreatic cancer. Thank you so much for having me and listening. Happy to take any questions.
Thank you, Dr. Donahue. That was incredible. Virtual question is, for a patient with borderline resectable or localized pancreatic cancer being treated at UCLA, if the tumor does not shrink enough after neoadjuvant chemo to proceed with the Whipple procedure, is radiation therapy the only next option? Are there no immunotherapy options available even if the patient has a KRAS mutation?
Yes, so good. It's a good question. So unfortunately, Dr. King's going to talk about the surgery. Fortunately, we're able to do much more complex surgery now than we used to be able to do. And again, that's another state-of-the-art treatment that we give you here at UCLA because of our expertise. But there are some patients who have either borderline or more likely locally advanced disease who get 6 months of FOLFIRINOX or 6 months of gemcitabine and Abraxane, and then at the end of the 6 months their tumor doesn't shrink, or it still involves too many blood vessels where we think it's unresectable, or it's not safe to proceed with surgery because it's too dangerous. And the options for them, we do have several clinical trials for those patients, including RAS inhibitors, including immunotherapy combinations. So the options would be continue chemo, de-escalate chemo, go on a clinical trial with some of these promising agents, or get radiation. But radiation, for the most part, I would say the data is somewhat mixed in this setting about whether or not it helps or not. But I like to tell patients this is where we or places like us come in really, really helpful. And this is our main niche, right? It's after you've finished the FOLFIRINOX or gemcitabine and Abraxane, which is in the guidelines or in the textbooks, where we can offer you some other treatment options that are very promising. I think you've been up longer. Yeah.
Okay. Hi, I was wondering, one of my previous jobs, I was talking to a customer and my allergies were acting up and I was like sneezing. And then he mentioned that, okay, people with allergies don't get cancer. And I kind of didn't believe him, but he said, yeah, trust me, I'm in the healthcare field. So that kind of stuck with me, and I just want to know, is there any validity to that at all?
I don't know that one.
Oh, really? Oh.
Yeah.
Because you got a hyperactive.
You have a hyperactive immune
Right.
system, right?
Yeah,
I
yeah.
mean, yeah, I potentially, potentially.
Right,
Yeah,
all right,
yeah.
thanks.
Hi, my name is Jay Sandler.
Hi, Jay.
I was diagnosed December of 2012, and in 2015, we did a liquid biopsy, and I had gone through FOLFIRINOX and gemcitabine and Abraxane and something else, I don't even know what it was. But after the genetic testing, he put me on Gleevec, and I'm here to say that's why I'm here to say. So it is so important, and if you're lucky, it's the world, it's everything. I have a question, and vein involvement it seems is a big is the thing that prevents surgery in a lot of cases. Is there anything being done? We hear a lot about chemotherapy and all the other things. Is there anything being done in actual surgical procedures or tools that could let more people get with involvement get surgery?
You gonna talk about this? Stay tuned. Dr. King is next. He's gonna talk about surgical approaches for pancreatic cancer. But the answer is yes. Yeah, absolutely. Thanks, Jay.
Yeah. Thank you, Dr. Donahue. So my wife has the ATM. If there is any improvement in the KRAS mutation, will that help patients with ATM mutation? It might be, maybe I'm not understanding the relationship.
Does she have a KRAS mutation too?
That I don't know.
Yeah, so we gotta get her tumor tested to see what her mutational profile is. But she has an ATM mutation in her tumor or in all of her body?
In her tumor.
In her tumor, yeah. So ATM is one of those proteins that helps to repair DNA. It's a signaling molecule, and it's thought that these patients are more sensitive or responsive to DNA damaging therapy, not necessarily immunotherapies, but yeah, there are. It can help to inform treatment, absolutely. Yep. I should say that we have a program here at UCLA, largely led by Wendy, where all of our newly diagnosed pancreatic cancer patients get germline testing. And this is something that's supported by UCLA and the Johnson Comprehensive Cancer Center. So when you see us here, if you have pancreatic cancer and are newly diagnosed, the genetic testing is on us. Just because we think it's so important. And it's also something that we're offering patients, not only if they see us in our Westwood or Santa Monica clinics, but we've set up a program where we now are alerted if there's a new pancreas cancer diagnosis anywhere in the health system, from San Luis Obispo all the way down to Laguna Beach. And we reach out to these folks via their UCLA MyChart app to make sure that they get the germline testing, at least for starters.
Hi, Dr. Donahue. Thank you very much for that progress report. It's really great to hear the progress that we're making, especially I was diagnosed in 2002 and was not hearing any of this. And also thank you for the reference to the 5FU. That's something that any of us that have done it, that's a favorite term for us.
Yeah, it's terrible.
Yes. And I almost hate to bring this up, but it's something that's been weighing very heavy on me recently, and I'm sure I don't want to get political and, hope we don't go there, but the recent budget cut that is happening, many of us have gone to advocacy yearly to get research funding and not to have it cut, but to hear that it's been cut 57%, and also the fact that I've been very honored to serve on the Department of Defense's pancreatic cancer research program as a consumer reviewer. That has been defunct, which means now we are getting nothing, which is only for, in particular for pancreatic cancer research. What is that going to do to us? I mean, our survival rate did not change this year. It's 13%, which is awesome, at least, it is coming up. But not to change this year, to have more people diagnosed, to have more people dying, and to have our funds cut and defunct and no longer be able to get it for pancreatic cancer research. Can you comment? Can you enlighten me? Or just, I don't really know if I'm what I want, but just some kind of, how is this going to affect pancreatic cancer in the future?
Yeah. It's a really great comment. Thanks for saying it. I mean, it's so disheartening to see what's happening to scientific research, and in our case, particularly pancreatic cancer research. It's the Department of Defense program that you talk about it was the culmination of so much hard work that was done by advocacy groups and whatnot to put the Recalcitrant Cancer Act bill into Congress that led to this Department of Defense program where there were funds that were earmarked for cancers like pancreatic cancer and lung cancer that are the more difficult to treat cancers. And that program just ended like that. And it's certainly an area or a disease that we need as much work, we need as much effort as we can, because we have made a lot of progress over the last few years for programs that are like this. I have funding from the NIH, the National Cancer Institute, that trial that I showed you with the adenosine inhibitor, that's part funded by the National Cancer Institute through a grant that we have. No one knows what tomorrow's going to bring. I do think that at least word that we've gotten is that hopefully the NIH budget is not going to go down by too much. It's thought that at least the research that they're funding, they're going to keep that at the level that they are, but they're going to redistribute it. And what's happening right now is that there's just been a pause button that's been hit, and they're kind of, figuring out how they're going to distribute things. But I'm hopeful. I'm hopeful that that there will be value seen in the work that we're doing. This is, the NIH is so important to help fuel our biomedical research enterprise, and it's the only way we're going to be able to make progress against diseases like pancreatic cancer. So unfortunate what's happened to the Department of Defense, no question. Hopefully that doesn't spill into other areas too. But I remain hopeful that at least for translational or research for really needed causes like pancreatic cancer, it's going to be okay.
Thank you. Is there anything that we as a group of people can do?
It's a good question. I mean,
Hate to put you on the
you can
spot,
reach
I'm
out to your
sorry.
congressperson. I'm not sure that they have any say right now, but not that I can think of. No. We just gotta let this process take place, and hopefully it'll be okay.
Well, thank you, and
course.
continue with the great work you're doing,
Thanks so
because we
much.
really do appreciate it. Thank
Yeah.
you.
Roll over to the next one. All right. Thanks.